All right. Thank you, Ashley. Thanks, sponsors. I'm Rob Manske from Wichita State University. Also work at Ascension Via Christi. I have to, Phil, you're okay if I give a shout out, right?
Of course.
I have
Mhm.
to give a shout out. I think it's a first time viewer, a guy that actually works with me, Jason Bena. So, Bena, shout out to you. Thanks for joining us. Phil, do you want to introduce yourself?
Sure. Phil Page from Baton Rouge, Louisiana. I'm a professor PT at Franciscan University. And I do want to give a shout out to, I see a few of my students on here, even our first years that just started this week. Thanks for showing up. And
Awesome.
and of course, we see the general
The
is
general,
the
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 Lord.
general's
general,
on.
the general's always on. I should give a shout out. I told our students too. I didn't look to see if they were all on, but hopefully some of them are on. Okay, Barbara.
Hi, I'm Barb Hoogenboom, and I hail from Grand Rapids, Michigan, and I am newly unemployed. I retired 2 weeks and 1 day ago.
Congrats.
Not that I'm not doing things, but I don't work for the university anymore, so I've got a little more free time and more time to edit papers and attend journal clubs. So that's the good part.
Awesome. And Barb, you already announced, I think just as we started, what number we are. Usually Phil asks what number. Number
All right, I
30.
don't
I
know if
have a
everybody
number.
was on when we announced it, though.
Oh, okay. So number 39. I have number 39 is my
Yeah.
my number. Hopefully that's right. All right, let's introduce our guest. We're like excited to have Dr. Meister with us. Dr. Meister, let me tell you just a little bit about him. If you've lived under a rock and you have no idea who he is, let me tell you. He's the team physician for the Texas Rangers MLB baseball team, the director of TMI Sports Medicine. He got his degree from Boston University. He has a combined BA MD. He did his internship at Mount Sinai Hospital in New York. He is fellowship, it looks like fellowship trained here, if I'm reading this right, in sports medicine. Hand surgery, too, Dr. Meister? Your fellowship in
Hmm.
hand surgery as well?
Yes.
Yeah,
Yep.
hand
Yep.
surgery, sports medicine, and
Mhm.
knee surgery. So we've got a great dude on with us tonight with a ton of experience. He sees the professional players. He sees a little bit of everybody. He does a lot of surgery. His specialty, obviously, is shoulder, hand, which I didn't realize that, and knee. And we're going to talk to him today. He's not only a great surgeon, he's a speaker, and he's also a very prolific author. And the two articles we're going to talk about tonight are two of his more recent articles related to UCL injuries. So, Dr. Meister, thanks for joining us. Is there anything I missed? Is there anything you'd like to tell us
No, I
about
just
yourself
just
that
to
I missed?
clarify, I don't do hand surgery
Oh, you
anymore,
don't? Okay.
and yeah, I don't even do knees anymore. Probably 98% of my practice is just taking care of throwers, actually. So.
Awesome. Awesome. Well, that's perfectly fine for us here today. I think we got two great articles to talk about. So, Dr. Meister, who did you do your fellowship under?
Oh, I was at the Orthopedic and Fracture Clinic in Eugene, Oregon. That was with uh, Ken Singer and Bob Larson and Stan James and some of the real old timers in knee surgery. And then I spent time doing hand end sports with Frank McHugh at the University of Virginia.
Oh,
And then
nice.
I spent my time with Jimmy, with Dr. Andrews, Dr. Clancy down in Birmingham. And then I spent another 6 months in London, England, doing some knee surgery and just traveling around, a little bit of a walkabout in Europe.
Yeah.
So,
Great. Great. A lot of great experience. Well, so why don't we jump into the first article? And our first article is going to be from the Orthopedic Journal of Sports Medicine. The title is Epidemiology of Elbow Medial Ulnar Collateral Ligament Surgeries in Major and Minor League Baseball Pitchers, a descriptive study of 2,281 cases. So this is one that Dr. Meister helped with. Multiple people, Dr. Camp, looks like Dr. Mehta, Griffith, Conti, Stan Conti, who's a athletic trainer. I'm not sure how to say Sophia's last name, but Dr. Chalmers and Dr. Hebert. So a great article to start with. I'll just describe the purpose of it, and then maybe you can tell us a little bit more about it before we get into questions here, Dr. Meister. But the purpose of this study was to highlight trends of medial ulnar collateral ligament repair and reconstruction in professional pitchers, describe outcomes such as return, to any level of play and identify factors impacting these outcomes. Do you mind giving us just a brief overview of what you guys found in that study?
Well, I think probably the most important things that we can take from this is that there's been a tremendous evolution in what's going on in the pitching world. Number one, and just in terms of incidents of injury that we're seeing, patterns of injury that we're seeing, and then alterations in treatment, and then ultimately how often we're seeing these things fail now, and going on to a need for a revision surgery, either a first time or even a second time revision. 3 types of elbow ligament surgeries, some repairs, some reconstructions, and whatnot. And unfortunately, we haven't seen a leveling off of any of these things. More the modern era of pitching is really the last 5 to 7 years or so, and that's when things have really changed for us. And as I said, we continued to see this uptick in injuries and recurrent injuries.
Yeah, it doesn't seem to be slowing down much at all. You're exactly right. We see way more UCL injuries than I think we've seen in the past. They just like you said over the last several years. The one thing that I've felt like I found kind of interesting in this study was the concept where you described the chronic, how you have chronic failure versus acute failure, and the fact that chronic occurs more often, which is probably why these can be sometimes misleading at times to what the actual pathology is. Can you tell us what kind of imaging you use during your, so if you initially see an athlete that you suspect has a UCL injury, is there, during your initial workup, what do you use to image different between someone who has a chronic failure versus an acute rupture? Is there different imaging, or what is your process you
Yeah,
go
I don't know
through,
that
or your
it's,
thought
yeah,
process
I
as
don't think
far
that
as
it's
imaging?
necessarily, yeah. I'm not sure if it's necessarily different. I think that one of the things I can tell you is that we never use arthrogram studies anymore. I think that if you're stepping into the what I believe is the modern era of managing these individuals with modern technology, I don't think there is a need for arthrogram any longer. I think that, and I haven't done standard arthrograms on the elbow for probably 20 years. And they're very, and we, in fact, many times these individuals come into us for a second or a third opinion, and we rescan them, irrespective of what they've already brought in with them. And we only get a very selective 3 views. We get what's called a coronal stir image, which is very sensitive, a very fluid sensitive image, and going to give us a little bit more acuity in terms of what's going on with the ligament. We get what's called a sagittal or a side view, PD fat suppressed, which is going to give us some structure and some fluid evaluation. And then we do what's called a fever view, which is something that many people are not as a very specific part of our workup for these individuals. So essentially, what that image does is it puts the thrower in the scanner and puts the elbow in a 90-90 position, and then we put about an 8-pound water bag on the arm. So it shows us whatever degree of medial joint space opening may or may not be there in an acute or chronic situation. And it's not the only thing that we rely on when we're being an important factor for us.
So do you, I've found myself that doing a exam, for ligament instability on the elbow and the medial, I've been tricked multiple times where I thought they didn't have a tear and they end up having an MRI showing that they have a tear, and they end up having, so you're seeing them conservatively and you don't think it's torn. You think maybe they just have a flexor pronator irritation, but it ends up, they go see the surgeon and it's actually torn. So you're completely, I've been wrong with my diagnosis before. Are you usually, when you do your physical exam, are you pretty usually good at telling that with physical exam? I mean, do you know ahead of time you're pretty sure it's going to be torn before you send them to get to the MRI, or are you tricked sometimes too?
Well, two things. I think that I'm a little bit of an advantage with most, because most of the time people are walking in already with a scan, and I've already reviewed them even before they've come into the office.
Yeah, yeah.
But that being said, I can tell you that probably 80 to 90% of the time, just by history alone, you're going to be pretty sure that there's some degree of involvement of the ligament. And what's really changed dramatically, I would tell you, over the last 5 to 7 years is the pathomechanics talking about UCL injuries. It's when I started in this game, when I was a fellow with Dr. Andrews back in the early 90s, almost every individual would come in with pain in layback. They'd have pain in late cocking, early acceleration, and that's what we're all taught to believe. I can tell you that now, that at least at the more elite level, and I think at the lower levels as well, that 90% of these people are complaining of pain at ball release. And so what's happened is that mechanically what's happening to the elbow is changed very dramatically. And nobody's actually done this biomechanical study yet. So everything that I can share is really just theory. And quite frankly, Dr. Elatrash out in LA and I have multiple conversations on a very regular basis about this, because the personality of these tears has it used to be the old time. I used to go to the Dr. Andrews meeting years and years ago, and we would hear Johnny saying, the old time pitching coach, talk, and how it would be necessary to be able to throw a baseball on a pitch effectively if you can take a raw egg and you can hold that egg and you can throw it without breaking that egg. Then you have a nice light grip on the baseball. But in the last 20 years, we've seen this precipitous rise in baseball velocity, and even more importantly, we've seen this huge increase in baseball spin. And even more importantly than just spin rate is the way the ball's moving. This horizontal ball movement that's being created is the requirement for this is now a very, very firm grip on the baseball. So kind of picture what's happening here. Way back in your layback position, instead of this kind of light loose touch on the baseball, now you've got this death grip on the baseball. So you're squeeze we never used to see before. And so you get this preloaded, so to speak, medial elbow until the point of ball release. And right at the point of ball release, you get this massive eccentric tearing that occurs every time an individual throws a pitch. And nobody really talks about this. But this is what is happening. And if you go back to the early biomechanical studies, and the one that everybody hangs their hat on is the Glenn Fleissig study, which and Glenn is a phenomenal biomechanist, but this is from 1995. And what that study shows, if you kind of dig through the details of the study, was that most of the valgus stress on the elbow in that study was seen in layback. But there's also a second peak of valgus load that occurs at ball release. And that was way back when guys were throwing the ball 10 miles an hour less and were spinning the ball substantially less. You weren't getting the kind of ball movement and this eccentric load on the medial elbow. So the primary culprit, which is occurring at ball release, is this eccentric load to the flexor mass, coupled with this spike as well in valgus load. And so it's creating now these very, very predictable patterns of injury that are occurring with much, much, much greater frequency.
Wow, thanks for explaining that. I haven't heard that before, and that's very intriguing. I'm going to have to get the Fleissig study myself and go back and look at it a little closer. So I appreciate you bringing that up. You mentioned about the uptick and the rise of UCL injuries, and we thought that its peak was a while back. What all you mentioned what you just said about the grip and the eccentric contraction. What do you think about, a lot of people say it's just because we have single sport athletes, they play baseball year round, the whole velocity issue. Is it all of that? Is it like to me, it seems like a lot of even these younger pitchers are getting bigger. I mean, they're like bigger, taller, stronger kids. Does that have to do with it too? What all other factors are there with this uptick?
Yeah, look, I mean, People talk about workload and year-round sports, and look, there's no question there is a contribution to that. But the problem with the baseball pitcher development now is that we're not developing pitchers any longer. We're developing throwers. And you have all of these facilities out there that are focusing on increasing velocity and increasing ball movement, not teaching individuals how to pitch and on the professional side go 162 game season and be durable and lasting, but just the single moment performance. Hey, I threw 98 today. I had 20 inches of run on my power changeup, or 22 inches of run on my sweeping slider. And that I think is a problem. It's these spikes in load that are just tearing apart these elbows, and now even the shoulders. We're seeing a much greater spike in very significant shoulder pathology that we've never ever seen before with the frequency that we're seeing it. So my problem isn't as much with the workload, and I'm not going to say that that's not a contributing factor. My problem is with these spikes in load that the body just can't handle. I mean, I say you can't drop a V12 in a Volkswagen and expect to. You can't train somebody. You can't train a hot rod to go ahead then and run the Indy 500. Looking at and goals that you're trying to achieve.
Yeah, no doubt, no doubt. Let's talk to Larry. Let's talk briefly here about what are your kind of key things you look at or do you do as you're trying to determine whether someone needs surgery or whether they can be treated conservatively? So for instance, do you do PRP or anything like that with partial tears or before you decide, okay, we need to go to surgery, or do you usually know ahead of time what your plan is?
I say look at the P's. I have my 5 and maybe 6 P's. I look at the individual in terms of position that they're playing. We look at the timing of the year that we're at as well. Do we have how does the calendar play in our favor? What kind of latitude we have? What is the potential upside of this athlete? Where are they going after they leave your office in terms of their career? As far as biologics go, I think the reality is there is not a single study out there that shows that PRP makes a difference in terms of outcomes. Probably the single best study that we have was one that we did on our professional ball players, where we took 100 that got PRP, 100 that didn't, and there was no difference in outcome. And so I tell this to patients always, and it's not that we don't occasionally use PRP, but quite frankly, I don't use it very much, and I don't think it's a substitute for rest and rehab, and ultimately don't think it's going to change the outcome of what happens to this individual. So now, who do we treat non-operatively? I think again it goes back to the personality of the tear, the severity of the injury. It goes back to where we are in the calendar year. So I think oftentimes we have to take many of those factors into account, because ultimately, if you rehab somebody and they don't do well, and they come in January, February, and then 3 months, 4 months later, you decide they need an operation. Now, unfortunately, you've missed 2 years rather than 1. And that's just the practical side of how we have to approach some of these things sometimes. So
no doubt that timing is a big issue that you got to look at for sure. So we only have one. Usually we have maybe people are just waiting to open the floodgates for the questions here, but we have one question from James Gallegro. Thanks for joining, James. Can elbow forearm counterforce compression straps or braces serve as a source of injury prevention, given the high grip forces that you talked about? Is there any counterforce brace or anything you feel like can help with dissipating some of the grip force you were talking about?
yeah, I think that nobody's shown that. I think that the magnitudes of the forces that we're seeing are so great and so concentrated that that there are a lot of gadgets out there. There are a lot of things that people try, and people wave at you and try and get us to utilize. But the reality is, when you're talking about the loads that we're looking at that occur so quickly, these spikes and loads that occur so quickly, and to such a significant magnitude, in the pitch that I don't know of anything.
Okay. Oh, looky here, guys. We have Kevin on. Kevin Wilk. Kevin, thanks for joining, man. We appreciate it. Kevin's got a question for you, Dr. Meister. Are you using stress ultrasound in the club exam?
I don't find that I can as accurately assess the ligament qualitatively and quantitatively as I can in an MRI scanner. I know the guys up in Philly are very, very big on stress ultrasound and they use it quite a bit. I just, perfectly honest, I'm just not as comfortable with it. Um, I think the quality magnet with our fever views that we get, the stress elbow MRIs that are far more accurate in terms of telling me what I need to see. I get a lot more consistency in terms of my ability to evaluate an individual. So I'm not saying that there isn't a utility, not a usefulness, but it's not something that I incorporate very routinely.
Good. So I think my guess is you've answered Todd Lazenby's question too. Does a good, well done dynamic ultrasound image ever substitute for an MRI, which you just eloquently answered for us, I think also. Kaylee
Yeah, no,
Shores.
I think even the guys, yeah, I was going to say, I think even the guys that use it a lot would tell you that it's not a substitute. It's a screening tool, and the times that I actually use ultrasound the most is if somebody is 9, 10 months post-op, they're having a little soreness in the elbow in their throwing program, and they need a little bit of a confidence boost that, hey, your ligament's okay. Don't worry about it. This is normal soreness. So we'll bring them in and we actually ultrasound the ligament rather than putting them in the MRI scanner, and we can give them something at least that they can hang their hat on.
Great. The questions are like flowing now. I guess we had to just prime the pump, I guess, and now they're like flowing here. Kaylee Shores is asking, what is your opinion on plyo balls and their relation to stress on the elbow? I wonder if by plyo balls, if maybe she means weighted. Do you think she means weighted balls, guys, versus plyo? I mean, plyo balls. Yeah. Do you have any opinion on use of plyo balls and how they stress
Well,
the
we use,
elbow?
yeah, I mean, I think obviously there are two different uses for it and usefulness for it. We do use it as part of a warm-up routine. We do use it as we introduce plows as part of our normal throwing program. I know the other article gets very, very anti. I think it's problematic in the young athlete. I think it's problematic even in the older athlete. I've seen older pitchers, major leaguers, quite frankly, ruin their careers trying to gain velocity by throwing weighted baseballs. And I think, again, it comes back to, are we teaching guys how to throw, or are we teaching individuals to pitch? And as pitchers, be durable and enduring through the course of not just one, but many, many seasons.
How often, Dr. Meister, I have a question, then I have a follow-up question from one of the people listening. But how often do you, on ulnar collateral ligaments, how often do you repair the tissue versus doing a reconstruction? Do you have like an idea of what your percentages are on the two of those?
Yeah, we the volume, the numbers we have are quite phenomenal, and also understand that most of what I see are very elite level. I mean, this year alone, from January 1 to the present, we probably done about 215 elbow ligaments, and 60 to 65% of what I do is pro. And in fact, right now, that's almost all I'm doing is just pro elbows. So we haven't seen a fall off that we typically see. So, but from a technical standpoint, I would tell you it's probably 70-30 reconstruction versus repair. And just to clarify that as well, if it is and repair the tear, and then we reinforce the tear with a brace and tendon graft, if it's a reconstruction.
Yeah, I was going to ask you about that just a little bit later. Another one of the questions: how often are you performing your Tommy John surgeries on catchers, and what is typically their return to play rate? So if you took everybody out except catchers, how often is that the patient you're seeing, and do they return fairly high numbers?
Yeah, I mean, obviously, the by far the number one group, better than 90% of these elbows are pitchers, and then probably less than 5 to 7% are position players, and the most frequent position player is catcher, and then they kind of a mix between left side of the infield and outfielders, corner outfielders typically, and as far as the return to play. Look, these position players do extremely well. I probably tend to put more braces, bone reconstructions in those individuals, and in catchers again, I think that's kind of dealer's choice, but they do well. Our timeline following a reconstruction to get catchers back can be about in the 10-month range, 10 to 11-month range. It's funny when you try and push them quicker, they just don't seem to do well, and they don't seem to be able to get back to that elite level of performance, normal pop times, and the things that they need to be successful behind the plate. So
you mentioned revision surgeries on a fair number of people now. What percentage of your population do you think are revisions?
Oh, probably about 15%, in what I call the modern era, which is the brace era, what I call the brace centric era, really, is kind of 2015 to the present. And in that piece of my database, we now have 160 revisions. About 100 of those are revision reconstructions, meaning hybrid reconstructions where we put an internal brace in with a tendon graft, and just over 60 are also what we call revision repairs, where we do this kind of our own little technique of two-layer revision, but repair rather than have to add tendon grafting to these elbows. And I would tell you that probably 80 to 85% of those are pro.
The big numbers, yeah, big pro numbers that you're
Yeah.
seeing for sure. Nathaniel Turner asked, you were talking about the grip and the eccentric load at ball release. Are there any studies do you know of that correlate grip strength with the rate of UCL injury? I think you said that it's something you see, but you haven't seen it in studies. Is that
Yeah,
right?
we've looked at that stuff. We've looked at different metrics to try and define what anthropometric parameters may actually lend itself to more velocity or more spin on the baseball, and grip strength being one of them. And quite frankly, can't find it. And it's probably it's clearly multifactorial, and what that mix of factors is hard to say, because the one thing we cannot measure is this neuromuscular control issue. And so there's something going on between the brain and the fingertips in these individuals that have an incredible ability to throw a baseball really hard or spin it really well, that we just can't measure. That's not something definable. There's probably something to measure. We just can't do it.
We don't know what it is, yeah, or not objective.
Yeah.
Yeah. I've got a good question here from Dylan. Hopefully I'm pronouncing this right. Fontan, Fontan. Thanks, Dylan, for sending your question to Dr. Meister. Given the evolving understanding of throwing biomechanics, workload management, and injury prevention, do you believe current throwing programs for overhead athletes, mainly baseball pitchers, are outdated? And if so, if you think they're outdated, what key areas should be modernized to better align with today's demands of higher velocity in pitchers? So, in essence, are the conventional throwing programs that most people use outdated? And if you think they are, what could be done? What could be tweaked to better fit today's throwers?
Yeah, that's a great question, and I think we do have certain knowledge that lends itself to maybe improving upon some of the older programs, and hats off and kudos to Kevin Wilk, because he's really been the pioneer behind structural doing it. I mean, really done a great job of obviously communicating these well-structured programs that have worked very well for a long time. So the question is, what other information do we have now that we can incorporate into this? And the thing that we use and we are quite dogmatic about is velocity. There are a lot of different toys out there that people espouse and say, hey, potentially these can be useful in measuring workload and regulating workload and whatnot. But truly, the only device out there and the only studies out there that have really been able to objectivize this aspect of it is actually looking at velocity. Because there is a direct correlation between throwing velocity and what the medial elbow sees. And so that's the only thing we have that we do know with some assuredness. So every one of our throwing programs, and it's structured very much like the old Kevin Wilk program. We typically start 60 feet or so, get out to 120. Some individuals like throwing out to 135, 150. If you start to get beyond 150, 180, then a lot of guys will break down their mechanics. And one of the things on the rehab side that is to me so critical is that you're maintaining a consistency, that you're maintaining your mechanics, that you're loading the elbow the same way every time. And then we objectivize this by using a radar gun. And so we build them a velocity chart based off of their fastball velocity. And so each one of these charts is individualized for the thrower, for the player. And that way, at least the loads that we are hopefully seeing on the medial elbow while they're throwing are increasing in a more linear way. I know there's a more recent, push out there. The reality is the Modus League does not accurately measure what's happening at the elbow in a very definitive, objective way. And so, again, velocity is really the best way to objectivize your throwing program.
I apologize. You were kind of cutting out, but I think, did you say that you set up their throwing progression based on their velocity and certain percentages of it? So it's individually based by each player versus just this is what we do for everybody. You really
That's correct.
that's genius. That's perfect. Yeah, I like that. Marty Hugel, who I think you know fairly well, he's got a question for you. Do you feel there's a long-term answer or solution to the elbow epidemic since we have now the desire for velocity and movement and speed with throwing isn't going away? So what is there, do you have a long-term answer of how we can fix this velocity problem?
Look, the only way ultimately we're going to mitigate this is by, I say, teaching individuals to pitch again rather than focus on throwing. Biology has changed in a billion years. So you're not going to build a better machine, so to speak. I mean, we can improve performances, but there is a breaking point for all this. And this is not going to change over the course of years or even decades. It's going to take a lot longer than that. And quite honestly, none of us have that much time. So the only way that this is going to change is philosophically the game has to swing back a little bit. And we're seeing a little of this at the professional level. And these are conversations I have had with everybody with the Manfred folks on down and on the pro side, because their contention always is, well, if it changes at the lower levels, it'll change at the upper levels. Well, that's impossible, because ultimately, if your scouts are going out there and they're drafting, and colleges are going out there and they're offering scholarships based on your pitch velocity and based on your TrackMan metrics, well, then that's what people are going to develop toward. So the philosophy of the game has to change. And one of the interesting things was, probably a month and a half ago, the Wall Street Journal actually wrote an article about the Tampa Bay Rays, who were at one point they had probably 9 or 10 medial elbow scars out of their 12 pitchers on their major league staff. And in 2023 and 2024, they were third and fourth respectively in the league in terms of sweeper usage. So big high eccentric load medial elbow, high horizontal movement ball, and one of the pioneers in this. Well, this year they've gone completely away from sweeper usage. In fact, they're 29th in terms of usage in Major League Baseball, and their starting pitchers have made every start this year. So you're hopefully, again, you're going to start to see the pendulum swing a little bit, at least, in the other direction. And really, ultimately, that's going to be the only way to mitigate any of this.
Yeah. Do you Chavis, I think Junior asked, do you think the pitch clock adds stress? Just based on the number of throws per game they're increasing because they're on a clock now. Is that one of those pieces of the puzzle too, potentially, or do you think probably not that big of an issue?
Look, Major League Baseball says not, but I also don't think Major League Baseball did quite a good enough job of maybe looking into this. I informally talk to pitchers all the time and ask them these things. Um, the younger pitchers, it doesn't seem to be an issue for. They've come up through the minor leagues with a pitch clock, and so when they get to the big leagues, it's not as much of an issue. The older pitchers, maybe so, and a little bit of their contention is the hitter has an opportunity to step out the box once during his at bat, but the pitcher does not have the opportunity to step off the mound. And so there are times where I do think if we look at specific instances where it would be nice to maybe add some kind of buffer in there in some way. The data at least doesn't show it, but we all know about data, and a lot of
Yeah,
it just
yeah.
depends upon how you're manipulating it and using it and looking at it. And so I don't think that there's a definitive yes, no here. Not for me anyway.
Okay. I might go back to the article just to get a little bit more discussion on the article, and then we'll come back to some more of these questions. We still have Dr. Meister, you're bringing it out of everybody. We've got like 17 questions there waiting to be asked of you. But in the study, the first study that we talked about, return to play rates were fairly high for the MLB players. It was 94.6. And in the study, they mentioned some larger sample size studies with larger sample sizes showing a lower return to play rate. And I wanted to ask you, and Dr. Meister, you probably don't realize it, but Phil, that's on with us tonight, is really kind of our statistical expert. I just want to ask the two of you, do you think, is there something to that, or is it really that just it's a larger sample size, so you kind of have a regression to the mean showing a lower return to play rate? Hopefully that question
No,
makes.
yeah, I think there are a lot of factors when you start to talk at major league versus minor league pitchers. I think if you just look at the individual first and foremost, it's a big jump going from the minor leagues to the big leagues. And I don't think people realize that. We rank and we rate these prospects all the time, and number one pitching prospect in all of baseball. But that leap to the big leagues, if you've never been there and never had to pitch at that level for a sustained period of time and stay there, that's a big step. And that's why it's so rare that you see a young pitcher come in and just dominate right off the bat and continue to dominate. There's a lot of adjustment that goes on there. So I think that an individual that is a veteran major league pitcher has a decided advantage in terms of his ability he's been there, he knows what it takes to pitch at that level. And I think that knowledge and that understanding is very, very critical. Number one. Number two, if you're a major league pitcher and you've created value for yourself, that means the team very often, and this is the reality of the business side of it, is probably going to invest a little bit more time and more patience in you because they think they're going to get more out of you. And so, unfortunately, at the minor league level, especially with reduced roster sizes now, so this stops in 2023, but I think that you're going to find that in 24 and 25 and beyond, that the numbers probably fall off a little bit in the minor leagues because a lot of these minor leaguers now are finding that they come off of surgery and they don't have a home any longer. So they got to go home, they got to rehab, and then they got to find their way back into the pro game. And a lot of them end up going to indie ball first, proving their wealth and their merit, or they go to the Mexican leagues, which is becoming a very, very, very popular avenue or pathway back to professional baseball in the States.
So great answer. We appreciate it. One of the last questions I have, and then we'll get back to or last question at least of this study, and then I'll get back to some of the viewers' questions. Both reconstructions and revisions in the study had lower rates of total return to sport at the same level compared to return to sport. And I guess can you explain that? I mean, to me, I would think I would see that with the revisions, but not 100% sure why with the reconstructions too. So why would
Yeah.
reconstructions also have a lower rate of
Primary.
return to? Yeah, yeah,
You're talking about primary reconstructions, first
yeah,
time elbow ligament surgery. And again, I think a lot of that lends itself because, again, at the professional level, excuse me, at the major league level, those numbers are different. At the minor league level, I think there's less of an opportunity and there's less patience within the game to carry these individuals along. As much as we try to accelerate in any instance is the process of return to play and that quicker, but I just haven't seen that to be the case. I mean, as I say, I go back to the point that biology has not changed
no,
over the last billions of years. And if you look at how long it took Tommy John, first operation, to get back to the elite level of throwing, again, all the studies that we've seen that have really looked at pitch metrics and how long that takes, it's rare that that first season back, somebody coming off surgery, they're done with a rehab assignment, they're 13 to 14 months out, that they come back and they're producing at the same level that they were prior to their surgery. And most individuals will tell you, yeah, I was back, I just didn't feel right until that next season back. So I think that that's part of the reason why. And at the minor league level, you don't necessarily have those extra lives,
yeah,
and the
yeah,
organizations are just not going to be quite as patient.
yeah. Great, good question, good answer. Um, Tomohiro asked, "What does thickening mean to you? And in your experience, do you see individuals with greater humeral retroversion exhibiting a higher frequency of UCL tears compared to those with less humeral retroversion?" So, two-part question: what does thickening mean? I'm assuming they're meaning ligament thickening. And then, when you see individuals with greater humeral retroversion, do you feel like do they have a higher frequency of tears compared to those with less humeral retroversion?
Yeah. Look, I could say that from the anatomy of the ligament side, thickening can be one of two things. Number one, somebody just has a thicker, larger ligament, and that's certainly possible. We've seen that in the ACL and the knee. There's no reason, you know, why we can't see that in the elbow. And for sure is looking side to side, dominant to non-dominant side. So I think unless there's something acute going on here, then it probably is not particularly relevant with respect to pathology or injury or whatnot. For me, I need to see something acute, some edema within the flexor, some edema within the ligament, or obviously frank tearing
We have
of the
a question.
graft, or excuse me, the ligament itself. As far as the humeral, go ahead. I'm sorry. Go ahead.
No,
Oh, I
go
was going to
ahead.
say the second part of that question about humeral retroversion. Yeah, the interesting thing about retroversion, that's something that myself and Kevin and those of us looked at many years ago. As part of these adaptive changes that occur in the throwing shoulder, and with respect to pure elbow ligament injuries, I know there's one paper, and I believe it was Kevin Wilk, that looked specifically at retroversion and the degree of retroversion and potentially a higher incidence of shoulder elbow pathology as a consequence of increased retroversion. But I don't know of any other studies that specifically have looked at that. Um, I think I can reason potentially that much more retroversion side to side, dominant to non-dominant. It may be an indication of how much they actually threw during those formative years when they were throwing. But I think again, that's a whole another topic of conversation that you could spend an hour plus on for
Yeah,
sure.
oh, yeah, yeah, yeah. Speaking of an hour plus, Dr. Meister, we still have about 10 minutes or so, but we haven't even got to your second article. So rather than try to rush it, we do this all the time, but what I would love to do is maybe have you back in 2026 sometime for another date if you would be willing to. We'd love to have you back. and we'll just go ahead and answer some of these, have you answer some of the questions from the viewers rather than, I just hate to rush we spent a fair amount of time on the first article, and I hate to just rush the second article in, like a 5-minute span. So I'll email you after we get done in maybe a couple weeks and see if you'd be agreeable to coming back. But I think we have, how many people did we have? How many people do we have on right now, guys? I saw we had like 350.
Yeah. We're
We
at
got
347
350.
right now, but we hit 358 at one point. So
Yeah. So Dr. Meister, I don't think anyone's going to argue about you wanting that are going to disagree with me that we wouldn't love to have you back in the future if you'd be willing to.
I appreciate that. I'd
You're
love
welcome.
to. Thank you. Yeah.
You're welcome. So Brian Lagan, a good friend of mine, is asking what your thoughts are on mechanics and the rise of UCL injuries, and specifically mechanics maybe related to like trunk rotation or hip rotation or things like that, where they're lagging behind or that type of mechanics of like the lower extremities and trunk. Do you think those what do you see there in regard to problems, and or is there a way to prevent those by fixing those type of issues?
Look, I think that I think the whole issue of mechanics from the standpoint of correctiveness or trying to correct them to the point of decreasing injury. I think that mechanics that are adjusted to increase velocity and increase baseball spin are potentially damaging. I think that that's a problem. And a lot of that increased velocity is coming from this increase in rotation. I always say it starts at the tips of the toes and ends at the fingertips. And so the more you're able to wind up the top, so to speak, you're going to create a better force and higher velocity. So I think that when you try and change, if you have an individual per se, and again, forget about the velocity, the performance issues. I think that mechanics to some extent are overrated from the standpoint that we say that there's not really been a single study out there that's actually correlated, certain mechanical flaws with ultimate injury rates. So I think from the practical standpoint, what I like to tell individuals and players all the time, you better dance with what brought you there. You've reached a certain level of performance because of the way you throw that baseball. Until that doesn't work any longer. And to start to screw around with degree of physical maturity, I think is probably dangerous and more often than not can lead to injury. And for instance here, if you look at Tiger Woods swinging a golf club when he was 7, or Prince Fielder swinging a baseball bat when he was 12, they look the same when they're 30 or 40 or beyond that. The neuromuscular patterning is already set in stone. And I think there was a study done years ago that the Canadian Olympic folks looked at exactly at this, and they found like you could be somewhat impressionable and change maybe some of these movement patterns up until about age 7. And beyond that, you kind of are what you are. And so I look at it like this: if you're the downhill skier and you're the first guy down that mountain, well, you can go ahead and pretty much put your skis anywhere that you want. You're going to be breaking new ground and breaking those tracks. If you're the 30th or 35th guy down that race course and you deviate too much from that particular track, you're going to catch an edge and you're going to blow out and you're going to fall. And that's how I look at throwing mechanics. You may be able to make some subtle adjustments, but if you start to try and change somebody too significantly, then I do think understand that their tissue has developed along these lines of stress for many, many years, whether it's ligament or it's bone or it's tendon or whatnot. And if you deviate from those patterns that these individuals are used to seeing, then I think it's going to result more often than not in a higher rate of injury. Again, my theory. That's
No, I got to be honest. I agree with your theory. This theory 100%, because when we occasionally will have pitchers come in, and the physicians or surgeons or whoever will want us to look at their throwing mechanics. And I agree with you. If they've been playing baseball for even just a couple years, if they're in high school and they've been playing baseball for years, even then it's hard to change their mechanics. And even if you see these kind of subtle little flaws, you can fix them and have them do the drills while you're there with them in the clinic. But my guess is when they go and play and it's like the heat of the game and they're trying to throw as hard as they can, they're right in the thick of it. They're not thinking about me telling them to, not horizontally abduct their shoulder as much or to follow through more. They're not thinking of any of that shit. They're just throwing the ball, right? So I agree with you. I'm not sure if we can really change it when they need it changed. I think it's very difficult, just like you said, years and years of neuromuscular changes and training that I don't know that we can stop with, one or two physical therapy visits discussing mechanics with them. So
Yeah.
I agree 100%. I don't know what the rest of you think, Barb, Phil, Ashley. Ashley, you work with a lot of golfers. Can you really change a golfer that's been playing golf for a long time? Can you change their mechanics that much?
No, and I mean, similarly, like we're in the flip side of that, we'll talk about with our golfers when we start to see their mechanics change. I mean, particularly in the world of hip, which was what I do, is you start to see breakdown of what their normal swing pattern is. It's been that way for 20 plus years. You're like, what's happening here? So I think that's a good indication that things are kind of going awry, and just the whole idea that, how many hours, how many thousands of swings does it take to ingrain a motor pattern? And if I have you do 10 really, quote, perfect swings or perfect throws, I just do it that way in the game. It's like they're always going to default back to their neuromuscular pattern that lives in their brain for eternity. That's their pattern that they've learned since they were little. So
I think that we sometimes fool ourselves to think that we can change someone's motor engram, their encoded pattern that they've gotten to. And like you said, Dr. Meister, that that's what they brought to this game, and that's their success. And I think sometimes we screw around in that a little bit too much. And I feel like we think that we have the answers, and we think, oh, if you open your hips a little more, you drop your elbow a little more, whatever. And it's like we're just not that good, and they can't sustain that. So I think that there's a lot of mythology out there about these major biomechanical shifts, that the motor engram is really powerful.
100%. I agree with you guys 100%. I'm going to drop down to the bottom here because this is it sounds like an interesting comment here from Bob Carlson. He said, I was with Curlin Job for the Tommy John on Tommy. Do you know Bob Carlson? Dr.
I
Meister,
don't,
do you
and
know him?
it's really interesting because the only other person that I thought was alive today that was in that room was Steve Lombardo, who was the fellow at the time at the Curlin Job Clinic. And I actually have a video clip that Steve did describing exactly the surgery and what went on in the operating room at the time of Tommy John's original surgery with Frank Job and Herb Stark, actually, the hand surgeon.
Well, so this Bob Carlson said he was there, and Tommy John also ended up having an ulnar nerve issue and transposition, which sounds like Bob is saying here allowed for more healing of the UCL reconstruction. Also, Tommy John not as much speed, though obvious more spin for his off-speed pitches. He's saying just for your information. So. For what that's worth,
fantastic.
I guess.
Yeah.
Yeah.
Well, I need to get his number in a video clip because, man, Lombardo thinks he's the only one that was alive during that procedure.
Well, Bob Carlson was there, it sounds like, too.
Yeah.
Guys, we're like we've got like 3 minutes. Do we want to go ahead and start the next session? Or how do we, I'm not sure how we transverse to our next area. Barb, I think you were going to maybe start our new.
Yeah. So this
Doc-
is just if that's okay, I think we could do it real quick. And if Dr. Meister, you want to hang around and listen, that's awesome. If not, we understand. But this is a newish feature where we're bringing in one of the residents, as was mentioned before. So Patrick, and I'm going to butcher your name. I'm sorry, Deleonibus.
Deleonibus.
I'm going to let you say it. Thank you. Is with us and from the ATI crew, and he's prepared a little bit of a discussion for us about this topic. And again, this is only our second time that we've done this, so we're really eager to have you with us, Patrick. Thank you. And also, for those in the audience, we hope you stick around and listen to this. It might go just a shade past 8:30, but or 8:30 my house, 7:30 your
Yeah,
place, all you
7:30
central
Central, yeah.
people. But anyway, and so I think that without further ado, Patrick, if you want to share your screen, I think we can get into a little bit of a sort of a case in point
Yeah.
presentation. Thank you.
Let's see if I can do this like we practiced earlier. All right, share. All right. And then let's get there. Okay. Does that work?
Not yet for me.
Not yet. There
There
you
we go.
There
You're
you
good.
go.
Okay.
You're good. Thank
Awesome.
you.
So yeah, my name is Patrick Deleonibus. I'm the ATI Sport Residency Site Coordinator down here in Charleston, South Carolina. So yeah, just to what I kind of prepared actually falls a little more into the second article we didn't talk much about. So hopefully this kind of gives a good summation of that. Based off kind of what we did last time, I picked 4 cases of patients that underwent UCL reconstruction. 2 of the 4 that are bolded, they actually went under the reconstruction with the internal brace. So kind of this hybrid procedure that was discussed in that article. 1 went under UCL reconstruction, and I actually saw him a little over a year after that surgery, and he had the ulnar nerve transposition. He was having issues during his throwing program, and talking to him, he felt like it was kind of rushed and he was just being pushed a little too hard and they weren't listening to him. He transferred to the college that I'm working at. And after that procedure, we kind of redid his rehab and he was successful ultimately. But just kind of using these 4 as examples, I just wanted to kind of go through the phases that article kind of walked through. And what I wanted to touch on is kind of more of like the issues that kind of come about in each phase. So as we know, in that first phase, it's pretty protective. We just got to be very mindful. The biggest thing I've come across now at the college, I have a little more ownership and control of my patients there, so I can make sure everyone's on the same page about the patients and educating the steadiness of the brace component to it. The high school students that we interact with, it's a little more complicated because we see them 2 to 3 times a week, but then the athletic trainer may not be as knowledgeable about it. Parents obviously are just parents and they want to make their kid happy. So, I think what I want people to take away is make sure you get your point across about following this early stage protocol to protect what the surgeon did. We want to make sure their surgery looks good, heals well, so that when we get to later phases, it's intact and the integrity of it is there for us. That next intermediate phase, again, the education for anyone who is helping with the recovery, mainly any athletic trainers at high schools who may not just be as experienced with it, or just PTAs or fellow clinicians that might be sharing these patients. Avoiding of the aggressive stretching. I have my 4th case there. He just came out of his brace and he's concerned about the lack of full elbow extension. We had a discussion with him and the surgeon on Monday that's fine at this stage. He's 7 weeks out. He's only lacking 4 degrees. We're going to get there. So again, just making sure you're taking that time to educate everybody involved in the case, educating your patients, just to make sure they're not overstretching. And then during this phase, I think in the article it mentioned returning to like weightlifting activities around the 10-week mark. That has been another hurdle I've encountered. Talking to strength and conditioning coaches and the team coaches and parents, again, what can they do and what is safe? So I think this article touched really well on what should be recommended. Start light weights, certain movement activities. And the way I like to think about it and tell them is try to keep everything in alignment. So that way you're not, again, accidentally creating that valgus stress on the elbow to where you're just compromising that repair. Now, the next 2 phases, and this is kind of what you guys were just talking about as well, as far as the mechanics and getting later into it. That advanced phase, again, we are just trying to balance everything for PT, strength and conditioning, make sure they're getting good recovery sessions, make sure the athlete's not being overworked during this phase, but making mindful progressions through it. And then again, with the plyometric progressions, my one athlete who had issues, he felt like that phase was very rushed. I believe this article talked about doing like 3 to 4 weeks of a 2-hand plyo and then going to 1 hand. We have actually implemented that before this article came out. That's kind of how I go about things, is doing about 3 to 4 week progressions, making sure everything is progressed one aspect at a time. So either volume, intensity, or the complexity of it. I try my very best not to do all 3 at once, just so if they do have an adverse response, I know what caused that. Now, that return to sport phase, when we are starting that throwing program, there are a few throwing programs out there. I usually kind of refer to the Kevin Wilk one as well. I like how this is mentioning the velocity component. We actually started that last year, adding that. Couple of the athletes didn't really have a good idea of what 60% felt like 70%. So we started diving in. Okay, what were you throwing prior to your injury when you felt healthy? Let's do a percentage of that, radar it, and then we'll use that as a progression as well. Now, optimistically, we always kind of hope you regain that full amount and maybe even improve on it at the very end when you are returning. But we use that as our base, so that way we do have a measurable amount for that. One thing you guys were touching on is the throwing mechanics and everything else that goes into pitching as a whole. I do talk to all of those pitchers individually about their arm slot. We look at their layback, what's their total arc of motion, how's their single leg balance, how's their core strength. We do that assessment in these kind of later phases and take a look at their throwing motion in a very slow down manner, not actually throwing, and try to get an idea of what it looks like. And then from there, we try to make that as mechanically sound as possible. I tell them from the get-go, we're not here to recreate your throwing and mechanics, because you've gotten here with that. We just want to try to improve and really prevent what we can. So in the past, it's actually been a lot of lower extremity issues have been an issue for 2 of these guys. It's amazing how bad their single leg balance with a little bit of upper body movement became. We worked on that, and they really gave great feedback when they went back to pitching. They just said they felt more balanced. They didn't feel like they had to overwork their arm to get the same amount of velocity and spin. They just felt more grounded in how they were pitching. So again, we do spend a good amount of time educating that and then making sure they are built up for that success. And then the last little thing I will put in as far as that return to sport phase and getting them back, taking everything we've done and working with them to find a good warm-up routine. 2 of them kind of had their own thing that worked pretty well. The other 2, they just did what the coaches told them. It wasn't all bad things, but one of them, I don't know if you guys have seen this, the coach had them doing like chain shakes, grabbing the chain link fence and shaking it as a warm-up. I had no idea what the purpose of that was. I was like, all right, we gotta find a better rhythm. So we kind of utilize just little parts of the rehab that we go through to activate the rotator cuff, to get some blood flow through the forearm muscles as well, and then just get core and lower body activated prior to going out and doing their full team warm up. So through the rehab process, we kind of find the ones that they respond best to, which ones they feel like get the best like bang for the buck, and then we just pull those aside and kind of establish a good warm-up program for them. So as far as, I think I might have jumped ahead and talked about some of this. Again, one component is, again, talking to coaching staff. A lot of them want to do their own thing. Trying your best to just educate and have an open discussion with them. At our college, we do have a good relationship, and we've been able to work and collab on a better throwing program that allows these athletes more time to get back to the competition. But just for a quick bringing it all together, the first 3, they all did, 2 of them did return in appropriate time levels. The The third one, he actually just had a appendectomy today. So he's on pause, but he is still on track to play this spring. And my fourth guy, he just started. So he did only have a repair with brace. His timeline will be 8 months at the beginning of their training in January. So we're hoping he should be able to maybe get some innings. But again, we've done a lot of education with him and the coaching staff that we can't rush this if you want him to be successful long term. And again, we've made that a big point to him not to rush this for this season. We want you at 100%, not 80%, and a risk of potentially having to do a revision. And that's all I got.
Thank you. Thanks very much. Appreciate it. Ash, you want to close us out? Ash and Rob, you want to close us out?
Yeah. So I mean, just we're good on time. We planned for 10 to 15 on this. So just thanks for doing that, Patrick. And I think it did help tie together a lot of what Dr. Meister talked about. And I want to give him an opportunity for any last comments. But I think, again, the keys on the importance of the individualization of rehab planning and programming for all patients, but particularly when you're getting back to sport, and that you have to take all of their personal influences, into account. So I think that was great. And Dr. Meister certainly talked about that. And the importance of, when we're talking about upper extremity patients, and I know Dr. Meister is big on this too, but like the importance of everything from nipple down, right? Like everything through our trunk, our core, our hips, our pelvis from the ground up, and how that influences what happens at the arm. And that's where, again, in living in my world, in the hip, I'm seeing them for their hip, but almost, if I talk about my major leaguers, a lot of them have already had Tommy John, and the correlation between people with hip issues and Tommy John's, like we could do a whole nother journal club on that. But so I just wanted to offer Dr. Meister any last parting words on, after going through those little case studies, and then we'll wrap this up and hopefully get you back in 2026.
Yeah, I just say two things. Number one, and you've talked about it already, is that none of these protocols are cookbook. And this is where we rely on you people, experienced physical therapists that are working with these people, that have hands on these individuals on a day-to-day basis. And that is by far the most critical thing here. What we put out there and put forth there are guidelines, and hopefully to provide some guardrails. But ultimately, it really is so important that you are you're using your own experience and your own intuition. When something doesn't look right, you're able to adjust. And most importantly, pick up the phone. And, I tell people all the time, I give every patient my cell phone number, every patient. And I say, if you're having a problem, text me, call me. I can't help you if I don't know. And that holds true to, for the therapist as well. And I think that obviously you're the eyes and ears of the surgeon. And we rely on you folks to give us that kind of feedback. And the only other thing I'm going to make a comment on is this question about 4 degrees of elbow extension, 4 degrees of elbow extension. So I think we get a little bit hung up on sometimes these, these nuances, or these tiny differences in range and at certain time points, and that lends itself back to more of a global feeling of, how is this elbow doing? Is it inflamed? Is it swollen? Is it something that I need to be concerned about, or are they healing nicely? And that's really more important than this again. A few degrees elbow flexion extension here or there. How does the elbow look? How does it feel? How does the athlete feel? That to me is the most important thing when you're looking at progression as you get through these programs. So,
yeah, both great points, and both reasons why people like you get invited to Journal Club. So
exactly, because we want that collaboration. We want physicians.
Yeah. And for someone like Dr. Keith Meister to say, I give every patient and every physical therapist my cell phone number, like, we appreciate you. We appreciate what you do for the patients, what you do for us as therapists. We hope we can have you back in 2026. For every 263 of you that stayed on to this very point, thank you so much.
Thank you.
Recording will go up tonight. Anything that comes up, please send me any questions, issues. There are 20 remaining questions in the Q&A box. We are sorry that we did not get to those, but we'll bring Dr. Meister back in 2026 if he will agree.
Appreciate you.
Yeah.
Thank you.
Everyone have a
Yeah.
great rest of your night and a great rest of your week, and we'll see you
Thank
next
you.
time.
All right.
Thanks very
Thanks, guys.
much. Thanks,
Thank
Dr.
you.
Meister.
Thank you,
guys.
Dr. Meister.